Well, good evening, and welcome to the latest edition of Charles Chats Fertility. I'm the group Charles Kingsland. I'm the group clinical director at CARE Fertility, and tonight we'll be talking about any aspects of IVF that you want to talk about, but there seem to be an awful lot of questions about embryos, embryo quality, how to prepare for egg collections, and all those associated things. So we'll try and get through as many questions as we possibly can. If we can't get through your question, then hopefully we'll be able to answer it after the programme finishes at 7 o'clock. And this evening, I've got joining me from the poshest part of Cheshire, our scientific director, shortly, because I hope so, because the first question is an embryo question. So, and
Hi.
there he is, right on cue. Hi, Ali.
Hi.
So we were just talking about you behind your back, but because we've got a lot of questions this evening about embryos and stuff related to the laboratory. So I thought it might be a good idea if we kick off and then you answer the first one, because it sounds very sciencey to me. So the first question this evening is, what makes a good embryo?
Wow, good question. Oh, yeah, it's a challenging question.
Probably a scientist, isn't it?
Yeah, let's start with the tricky ones. So, well, clearly, an embryo is made from an egg and sperm. So we need to have a good quality egg and a good quality sperm. And then in IVF, of course, we need an excellent embryology laboratory and wonderful embryologists, very experienced and talented. And so all of those things together, I think, are the magical recipe for a good quality embryo. And some of it we can't control very much, but certainly the lab aspect and the quality of the technical ability of the embryologist, we have great control over. Egg quality and sperm quality, I think we'll probably talk about a bit more detail. We obviously would deal with a lot of sperm, generally in one semen sample, so we have methods to prepare the sperm so that we concentrate the better quality ones. With eggs, the numbers are always more limited, and I think you probably should tell us about the factory and the warehouse analogy.
I knew you would probably refer to that. Yeah, well, the next question here is, how can I improve egg quality? And the description I always use when we're talking about eggs and sperm is a sperm. Men are sperm factories, so that we've got all the ingredients in our bodies to make sperm every day of the week. Some days we're good at it, some days we're bad at it, but it usually takes us about 6 weeks to make a sperm from the raw ingredients. And that differs from a female who is an egg warehouse, because all of a female's eggs are ready made and are there by actually the 20th week of intrauterine life. So a girl has a maximum number of eggs before she's born. Now, the thing about eggs is that they're already made. They're like meat pies on a shelf. You can't change the ingredients. You can only, all we do, or what a female will do, each month she will take one egg and mature it in the first half of a cycle and then ovulate it in the second half of the cycle. So how can you improve egg quality? Well, it's very difficult to improve egg quality. What I would say would be to turn that question on the head, and how can you preserve egg quality? So there are certain things you can do that can make you can keep your eggs as healthy as possible. Don't smoke. Eat a good diet. Try not to be overweight. Try not to have nasty illnesses. And if you do have illnesses like diabetes, for example, try and keep them as well controlled as you possibly can, because the better controlled you can keep your medical disorders, the better chance you have of preserving the quality of your eggs. The biggest aging factor on eggs is age itself, because age more than anything can affect the quality of your eggs. So that when a female is in her 20s and early 30s, she's at her maximum fertility. Once you get over the age of 35, then your egg quality deteriorates quite quickly, and then over the age of 40, it drops like a stone. So once eggs, once eggs have become less effective, it's very difficult to, if at all, to improve the quality. There are certain things on the market that you can purchase. DHEA is one. There are lots of products that you can see on social media. But when you are utilizing or thinking about buying these sort of things, what you have to remember is that there is little scientific evidence to support the notion that these products improve the quality of your eggs. Whenever you go to a doctor or any medical practitioner or any complementary therapist, it's always worthwhile remembering that important phrase. But what evidence have you got, doctor, that what I am telling you is unequivocally going to be of benefit to me? So if I said to you, for example, to improve your chance of having a baby, take folic acid. Patient may say, well, what scientific evidence have you got that this is going to improve my chances? Well, I can lead you to the library and show you beyond doubt scientifically proven data which tells me that by taking folic acid, if you take folic acid, you've got a better chance of having a healthy baby than if you don't. Unfortunately, there are a lot of products that we advocate, that are advocated, don't have that same scientific basis. But provided you know that is the case, then you are free, to try anything you want, provided that it's not harmful. There are some things that can be quite harmful, but you've got to be very careful when you're taking, for example, some forms of Chinese herbal medicine. They may contain things that can be harmful. So you've got to be very careful when you're purchasing these complementary therapies to know which ones are scientifically proven, which ones are not scientifically proven, and which ones can be harmful. Is there anything you'd like to add to that, Ali, about improving egg quality?
Well, no, I think that was a really comprehensive answer, but I was just monitoring some of the messages and questions just coming through on the feed. And I think initially when you were saying about egg quality decreasing with age, one lady was saying, is it a waste of time having a treatment after the age of 35? But somebody stepped in, one of your patients, as age 41, who has had IVF and is pregnant. So it's not a waste of time. It just might be a little bit more challenging, but
yeah, absolutely not. And that's a bit like saying, well, should we be having sexual intercourse over the age of 35 to try and have a baby? Of course. It just means that it may take you a little bit longer to achieve a pregnancy naturally, or with IVF your chances might be a little bit lower than they were when you were 25. But that doesn't mean to say you shouldn't have the treatment. On the contrary, it may mean that you should have the treatment earlier. So moving on to the next question. Does ICSI increase the chance of an embryo forming from fertilization? Now, ICSI stands for intracytoplasmic sperm injection, and it's where one single sperm is injected into the egg. But Ali, you probably tell us the difference between IVF and ICSI.
Yeah, well, when I first started out as an embryologist in early to mid 90s, ICSI was a very new phenomenon. I mean, now it's well established, highly successful technique for fertilization. So in those days, if the sperm numbers were low or the quality of the sperm was poor, we really struggled to achieve fertilization, and sometimes IVF wasn't possible. So conventional IVF, where the sperm is prepared and mixed with the eggs, we need certain numbers to be able to do that effectively. So ICSI was a revelation. So this time we take micro manipulation equipment, we take a single sperm into the end of a very fine glass pipette or needle. So it's 10 times finer than a hair. And we then control the movement of that sperm and we inject it into the middle of the mature egg. And the success rates are amazing, equivalent to IVF. I mean, the benefit, I guess, of ICSI over IVF is that we ensure the sperm gets into the egg and then it's got a jolly good chance of fertilizing. IVF is more of a natural, longer established technique where you mix them together and one sperm hopefully will bind to the outside of the egg and make its way in to fertilize. So we do see a slightly higher failed fertilization rate with IVF because the sperm has to get through the shell, the zona pellucida of the egg, whereas with ICSI we can just put it straight inside. But we don't do ICSI unless it's indicated, unless the sperm quality or sometimes the egg quality indicates that we need to.
Should we be doing ICSI on everybody then, and not bother with IVF?
I don't think so, no. Some clinics around, mostly in the States, would advocate doing ICSI for everybody. We do see a lower failed fertilization rate, but it's more invasive. We do sometimes see damage to the eggs. So there are pros and cons of all techniques, so IVF and ICSI alike. But we don't recommend ICSI unless we need to do it. But when we do recommend it, we're very confident in it, and at least 50% of our patients do actually have ICSI.
Yeah. Okay. There's a quick fire embryology questions now, Ali. Does using embryo glue increase your chance of a pregnancy?
Right. Well, embryo glue it's a transfer medium. It's quite viscous. It's got hyaluronan in it. It's like a protein supplement in it. And some studies show that it can improve the chances of implantation if it's used at embryo transfer. We don't understand why necessarily. The science behind it isn't really clear cut. We certainly consider it does no harm. In our hands, we haven't seen a significant improvement when we use it. But if patients request it, then we talk to them about it, and it's very simple and straightforward to use if we need to. Okay.
I've 6 frozen embryos and we have used Caremaps. How will that inform the selection process? So this is a general question about Caremaps, I think.
Yeah. Well, Caremaps is it's an excellent tool to inform embryo selection. So it's something that we've developed in-house at CARE Fertility over almost 10 years. So basically what it does is it involves the use of time-lapse imaging. So the embryos after fertilization, they're imaged every 10 minutes, so photographed every 10 minutes from insemination if it's ICSI, or from fertilization if it's IVF, right through to the point of embryo transfer. And the embryologists are constantly monitoring these images. So we're assessing the time that each embryo comes to the next cell stage. So the exact time it makes 2 cells or divides to 4 cells and so on. And very recently we've launched our latest version of Caremaps. It stands for, the MAPS stands for Morphokinetic Algorithm to Predict Success. So morphokinetics are these timings that I'm talking about, that the cell number increases. So we've launched our 6th version of it very recently, and this is based on the transfer of 6,000 embryos where we know if a baby has resulted or not. So if you imagine, we've got 2 big groups of data. One group, we've got all this morphokinetic information for all of them, but one group, the embryos didn't make a baby, and the other group, they did. So we've used very complicated mathematical analytics and developed an algorithm which tells us, based on these developmental patterns, which embryo has got the best chance of making a baby. So with this case, where there are 6 embryos, they've been through the Caremaps program, we will have a Caremaps score for each of those embryos, and we will choose first the embryo with the highest Caremaps score because we know that will give the best chance for a baby.
And the other nice thing about Caremaps is the embryos are not disturbed because they're in a closed incubation system. So you can actually view them on the video screen without having to take them out and look at them under the microscope, which must be of benefit to the embryos as well, isn't there?
Yeah. Did you see the guy on the news the other day? I don't remember who he was, a politician, talking about the mum test. And I was thinking, oh, that's a bit strange. But actually, I do the sister test. You know, if my sister was to come for fertility treatment, what would I say she should have? And Caremaps would be right at the top.
Yeah, I would agree with that. Okay, should all couples consider genetic testing? Well, I would say the answer to that is no. Ali's just been talking about Caremaps, and this is a morphological assessment of the embryo. So we're actually looking at the quality of the embryo, what they look like, and how they've divided, how quickly they've divided, and that gives us an idea as to the quality of the embryo, as we've just discussed with Caremaps. We don't know, however, what the genetic constitution of that embryo is without looking at the chromosomes. So that would involve, to actually go one step further from Caremaps, that involves actually biopsying an embryo. And normally you'd take 5 cells out of a 32-cell embryo, and that embryo would reconstitute, so it doesn't damage the embryo. And then you'd look at the chromosomes in those 5 cells, and that would give us an idea whether the chromosomes in that embryo are actually normal. So whether that embryo is a normal embryo or not. And it will also give us an idea as if it's abnormal, how abnormal it would be. So that's the gold standard. However, it doesn't improve the quality of your embryo. It just tells you which embryos may not turn into a baby. It won't tell you which embryos will turn into a baby. It will tell you which embryos are likely to turn into a baby, but it will also tell us which embryos won't turn into a baby. And you know, we could talk about for an hour just about the pros and cons of genetic testing, but generally speaking, it is not essential. It is not advisable for every patient. There are certain patients where it may be applicable. Patients who've had multiple miscarriages, for example, so we can have a very close look at the embryo. But the best advice you should be able to get is from your doctor or the embryologist in the clinic, and they would advise you whether the pre-implantation genetic testing is suitable or advisable for you. What are the pros and the cons, how much it costs, and then the decision can be made jointly between yourself, once you've been informed about it, and the clinic itself. Is there anything you'd like to add to that, Ali? Or I might have made a mistake.
No, you've not made a mistake. No, I think, I think to keep it simple, in general, because you know every case is different and each couple of patients will be given all the appropriate information tailored to them, but in simple terms, embryo selection is really important. Most patients are fortunate enough to have more than one embryo, and the difficulty is how do we choose between them. So for generally speaking, again, for patients where the female is under 38, we would strongly recommend Caremaps. Over 38, then we recommend PGTA, this aneuploidy screening, because the incidence of the eggs having the incorrect number of chromosomes really increases above that age.
Yeah.
So that's the gist, I think.
What patients sometimes don't realise, or what we don't realise, is that in natural conception, the majority of human embryos are actually abnormal. That's why we don't get pregnant every month. In fact, you know, over the age of 40, 75 up to 75% of naturally conceived embryos are abnormal. Whereas when you're 25, it's much more likely to be 50-50. So what we have to do is utilise all our scientific expertise that we have at CARE in our laboratories to pick out which embryos are likely to turn into babies, and that's Caremaps, and then, as Ali said, in some circumstances, PGPA. Okay, can I add Caremaps at any time to my treatment, Ali?
Well, yeah, I've seen lots of questions coming up about Caremaps.
Yeah.
It's the best way to have Caremaps is from the beginning. So from the day of egg collection, you could decide, actually, I've been thinking about it, can I have Caremaps? And we can arrange it almost always. Sometimes capacity might be limited because these are very sophisticated incubators with only a fixed number of spaces, but we have capacity generally in all of the clinics, almost all of the time. So you just need to ask. The difficulty sometimes is with NHS funded patients. In some areas, we're not permitted to offer anything additional. And of course, Caremaps is an additional service. So the only thing I can say to try to compensate for that, because it is a special technology and it's very, very successful, is that because we have almost a decade of experience with it, we have applied many of our learnings, the ones that we can from all that time-lapse imaging, and an understanding of the precise timings that embryos should meet these milestones. We've applied what we can to standard incubation, which is normal. They're excellent standard incubators, they just don't have the camera system in. So we've applied what we can to enhance success rates also in the standard situation. So we can explain more about that if you have any direct questions.
So Ali, here's a difficult question, but I'm going to ask it anyway, and I'll answer it first, and then you can correct me. What is the lowest quality embryo you will freeze that you would expect to result in a pregnancy? Well, I would say any embryo that we think has any chance of turning into a baby, and it's a spare embryo, we would freeze. What would you say, Ali?
Yeah, it's probably not quite as clear cut as that. So when we're grading an embryo, depending on which stage it's at, but let's say it's at the blastocyst stage, which is the stage we're aiming to get to with embryos for transfer. So they have then at that stage, which is about 5 days after the egg collection, they have two types of cells. So the trophectoderm cells, which are all around the edge, and they will become the placenta if everything goes to plan. And there's a bundle of cells inside called the inner cell mass, and they're the cells that become the fetus and then eventually the baby. So we try to grade both of those cell types in the blastocyst. And the most important, it seems, when it comes to success rates and surviving a freeze-thaw process is the quality of the trophectoderm cells. So if they're insufficient quality, then we know they won't survive the freeze-thaw, or if they don't have enough of those cells, we know they won't be viable, they won't be able to make a pregnancy. So what we do is we talk on a one-to-one basis with the patients and explain the situation. And if we do think there's a small chance, then we've talked to them about that, because some patients, they want to take a small chance. Many patients want to take a small chance. If we say, we believe there's a less than 5% chance of this embryo resulting in a pregnancy if we freeze and thaw it, many patients will say, I'll take that chance. Others will say, well, I'd rather leave it. I've had my fresh transfer often. I'll see how I get on with this. And then I'll put that money that I would have been paying towards a frozen embryo transfer towards another fresh transfer. So it very much depends on the patient's situation, the embryo that we're faced with, and we've got so much data and experience in order to help patients make those difficult decisions.
Okay, so we're going on to the transferring embryos now. Tips for preparing for an embryo transfer, please. Right, well, I would say that first and foremost, if you have an embryo ready for transfer, that's a positive sign. So that's good. So positive. Positivity helps. Take your folic acid. Make sure you've been taking your folic acid. And what I would say for patients coming to see me before the embryo transfer is make the embryo transfer a priority for your day. Don't fill your day with other things that you have to do. Make it a priority. People often feel that stress can impact negatively on an embryo transfer, but we're all stressed. There's very little evidence to suggest that mild stress or even moderate stress has a negative effect on your chance of getting pregnant. It's only when stress becomes overwhelming and becomes distress, and it alters your, the way that you lead your everyday life, that can affect outcomes. If you want to have any complementary therapies like acupuncture, if you believe that acupuncture may be of help to you, or reflexology, then speak to your clinic, who I know Zita West Owl Clinic in London. They are world leaders in complementary therapy, and they have a lot of very useful information about complementary therapy before an embryo transfer. Ask questions if you want to know more about your embryo. There'll be an embryologist on hand. There'll be the doctor, and make sure that you've asked all the questions, however daft you may think they are. They're important to you, and therefore they're important to us. So is there anything else you would say about embryo transfers from a scientific point of view, Ali?
No, I don't think so. I was thinking of an emotional point of view, and the difficulties that patients are facing at this time, when we're having to restrict partners coming into the embryo transfer room, and I think that must be really difficult, but we try and help as much as we can throughout that process, and sometimes patients arrange a FaceTime, or we take photos and send them, and send the thoughts and wishes into the car park. But it's very tough at the moment. But
can we see our embryos before they go back? Absolutely. The majority of our clinics will show the embryo to you and describe the embryo to you before you have your embryo transfer. But also, and importantly, all of our clinics do ultrasound guided embryo transfers. So that's where we use ultrasound technology to help us put the embryo in exactly the right place in your uterus, so that you can see that embryo going in. Now, as far as I'm concerned, using ultrasound, putting embryos back, is like eating your dinner with the light on. You wouldn't consider eating your dinner in the dark if you could switch a light on and see what you're actually doing. And it's the same with any technique. To do it better, you've got to be able to see what you're doing. And ultrasound enables you to see what you're doing, and it actually appears in the NICE guidelines. The National Institute of Clinical Excellence actually say that if you have an ultrasound guided embryo transfer, you have a better chance of success than if you don't. So that's why we do it at CARE Fertility, to give you the best chance of achieving a pregnancy. Does embryo transfer hurt? No, it shouldn't hurt. I mean, obviously, it's not the most pleasant thing you're going to have in the world, and dignity has to take a back seat just for the time that you're having your embryo transferred. But it's very similar. I would liken it to having a smear. The only discomfort you should feel really is having a full bladder. We like patients to have a full bladder while they're having the embryo transfer, because the bladder, the weight of the bladder actually flattens and straightens out the cervical canal. So it makes the embryo transfer technically easy for the doctor or the nurse who's performing it, although you might feel a bit of discomfort with a full bladder. But rest assured that once you finish the embryo transfer, then by emptying your bladder, it doesn't have a negative effect on the chance of getting pregnant. What you have to remember is that the bladder is lower than where the embryo is, and as you stand up after an embryo transfer, your embryo actually floats further upwards. It's a bit like a bubble in a bottle of pop. If you turn it upside down, the bubbles go upwards, and so by standing up immediately after an embryo transfer, that doesn't have a negative effect. In fact, many scientific studies have shown that it has a positive effect. Similarly, when you go to the toilet to empty your bladder afterwards, that that actually pushes the embryo further and further up. So those are two very positive things. Don't think that you've got to lie down for hours afterwards. In fact, evidence suggests that if you stand up afterwards, then you have a more positive chance of getting pregnant than if you lie down for a long time. Do you allow people to have 2 embryos put back, or do you advise against it? Ali?
Well, it depends. I'm getting all the depends questions.
That's why. Yeah, because it depends.
Yeah, we advocate single embryo transfer almost all of the time. There are some situations where we'll discuss and we can be more open-minded with a double embryo transfer. But generally speaking, single embryo transfer is the best, it's the safest. As we've described, we're very good at embryo selection. We have excellent results. We don't want twin pregnancies. They can be harmful for each of the babies, for the mother. There are risks, and there's no need to take that risk because the freezing of any other embryos is phenomenally successful. I've seen some questions coming in about fresh versus frozen. We see the same results with fresh and frozen embryos.
Which wasn't always the case many years ago. That's why we used to put back more fresh embryos, because our freezing techniques were just not up to the standard they are nowadays, and that's why multiple pregnancies were commoner many years ago, because we had, out of necessity, have to put our fresh embryos back, just simply because we didn't have the freezing technology that we have nowadays. And you have to remember that if you have 2 embryos, if you put one back and then the freeze one and then put that one back sometime later, you've got a better chance of having 2 healthy babies than if you put those 2 embryos back at the same time. Because we all like the idea of having a twin pregnancy, especially when we've been trying for many years to have a family. But what you also have to remember, and Ali's alluded to, you are 5 times more likely to miscarry a twin pregnancy than a singleton. So for every twin babies that we see being pushed around the local supermarket, people don't see all the heartbreak of having premature or miscarried or ill twins because of the fact that they're twins. Because humans are designed to have 1 baby at a time and 2 at a push. So for us, twins are never, it's much better to have as many babies as you like, but 1 at a time. Okay, quick fire questions. Ali, please can you tell us about fragmentation?
Fragmentation is it's made from the cytoplasm, the stuff that makes up the embryo. So when an embryo divides, as it should, into 2 cells, 4 cells, 8 cells, sometimes little parts of the cells break off and form little fragments. So we use the quantity of fragmentation and sometimes the distribution of the fragmentation around the embryo to get an indication of its quality and to grade it. So the more fragmentation we see, generally speaking, the lower the chance of that embryo resulting in a pregnancy. So it's a normal phenomenon. It's quite rare to see no fragmentation at all, but generally we will see some, and we'll choose embryos for transfer with the least fragmentation. It's just one of the measures that we use when we're assessing and choosing embryos. We suspect that it may be to do with a mechanism of correcting. The embryo knows there's something wrong, or it's got a little part of it doesn't want, it can extrude it, it breaks off. So, I mean, there's still a lot to learn about fragmentation, but it's an important and common phenomenon.
Thanks, Ali. Well, the questions are still streaming through, and we've run out of time. So we will try and answer as many questions as we possibly can. And if you have any more questions, then just keep them coming, and we'll answer them as and when. So that's it. Gosh, that was a quick 35 minutes. What's your husband making for dinner tonight, then, Ali?
Some halibut, I believe.
Very nice, very nice.
Yeah,
Some
very lucky.
a nice dry white from the cellars as well to go with that.
Well, he's not drinking for this lockdown. He's on a special healthy diet, so I'm trying not to show him up.
Gosh, and I've
Yeah.
got and I've become an alcoholic. But anyway, that's my problem. Okay,
It's
well,
not good
thanks,
for you, Charles.
thanks, Ali, for joining us tonight. I'll see you soon, and thank you everybody for taking the time to spend with us. And see you again next week. Bye.
Thank you.